So pulmonary fibrosis is a group of diseases, around 200 different diseases, that all affect the lung, in particular the part of the lung where oxygen transfer happens. So lungs become scarred, patients become more short of breath, and ultimately it results in respiratory failure and, in some cases, death. There are many different causes, but about a third of the cases we see are caused by an underlying autoimmune rheumatic disease. About a third of cases are caused by pollutants, which includes smoking, and about a third of cases we never get to the bottom of. These are the true idiopathic cases. So this is a very important question. Pulmonary fibrosis covers all the different interstitial lung diseases, all 200 of them. Idiopathic pulmonary fibrosis is a very specific diagnosis, so patients have to meet very specific diagnostic criteria, which essentially means excluding any of the known causes of pulmonary fibrosis. And what we are left with is truly unknown cause for the pulmonary fibrosis. And it tends to be a disease, not exclusively, but of older men. So about 70% of the patients we see with idiopathic pulmonary fibrosis are older men in their 60s to 70s. However, still 30% are females, but these are often older women as well. So again, another really important question. We know that one of the big risk factors for developing idiopathic pulmonary fibrosis is to have a first-degree relative with the disease. So it's very important, if you know that you come from a family where pulmonary fibrosis is prevalent, that you do bear this in mind if you develop any shortness of breath. For the other diseases, we know that a third of the patients we see have an underlying autoimmune rheumatic disease. So these are diseases that you'll have heard of, like rheumatoid arthritis, systemic sclerosis, and many of these patients will develop interstitial lung disease or pulmonary fibrosis. And then there are a third of patients who develop pulmonary fibrosis because of exposure to pollutants. We know that smoking is a risk factor, and we know that some drugs and some treatments, such as radiotherapy, can cause scarring of the lung. So there are many different causes. This is an area of enormous interest. At the moment, we have no way to prevent pulmonary fibrosis, but what we can do is we can slow it down. So if we know that somebody has pulmonary fibrosis because of ongoing inflammation secondary to another autoimmune rheumatic disease, such as rheumatoid arthritis, then we know that treating the underlying autoimmune disease can help prevent the pulmonary fibrosis and may even reverse it. However, if the pulmonary fibrosis is established and it is progressing, we call this progressive pulmonary fibrosis. There are a lot of nomenclature here. And in these cases of progressive pulmonary fibrosis, or PPF, what we hope to do is slow down the progression. It's unlikely that we will halt it with our current drugs and treatments. But what we know is some of the treatments we have available, nintedanib and pirfenidone, will slow down the progression of the disease. But we also know that actually staying healthy, using your lungs, taking exercise, eating a healthy diet, maintaining a healthy weight, all of these we hope will slow down the progression of the disease. This is a really difficult question to answer because many of the symptoms of pulmonary fibrosis are very non-specific: cough, shortness of breath. But what I would say is if you have a cough that's been going on for more than 6 weeks, you should definitely see your doctor, whatever age you are. It probably isn't pulmonary fibrosis, but it should be investigated. If you're getting short of breath, be very, very careful before you attribute this to increasing age. I think many people think they expect to be short of breath as they get older, but actually that's not really true. So if you're short of breath, go and see your doctor, get yourself checked out. It's likely to be something other than pulmonary fibrosis, but it might be pulmonary fibrosis. And this is particularly important if you know that you have a family history of pulmonary fibrosis or you have a first-degree relative with pulmonary fibrosis, by which I mean a parent or a sibling. So in most cases, the definitive test to diagnose pulmonary fibrosis is what we call a high-resolution CT scan, which is a CT scan of the chest. You go through the imaging, it's like a donut, and you go through that, and you have what we call a high-resolution scan, which shows the lung in a lot of fine detail. This is almost always organised by a hospital specialist. So it may be done for another reason, and the lung fibrosis is picked up incidentally, or it may be done because you've been referred by your GP because you have a cough and/or shortness of breath. The whole process from referral to the GP, if that's the route that you took, to the hospital specialist takes about 6 weeks from first referral, and then the CT scan will be done within 6 weeks after that. So I would say from first seeing the GP to getting the diagnosis may take up to 12 weeks. So when we think about treatment, I always think about non-drug treatments and drug or medication treatment. And in the non-drug treatment, we include pulmonary rehabilitation. So these are exercise classes which encourage you to do more exercise so that your muscles become more efficient and they need less oxygen. Also, within the non-medication group, we include oxygen, which is itself really a medication, but that can be prescribed either at rest if you have very severe lung damage and you need oxygen all the time, or just overnight or when you exercise. So these will all help you with the symptoms, but they won't actually reverse the pulmonary fibrosis. For drugs or medications for pulmonary fibrosis, we have 2 drugs that won't reduce the fibrosis, but will slow it down so it doesn't get worse so quickly. And these drugs are nintedanib, or Ovef, and pirfenidone, or Esbriet. They work in slightly different ways, but they have remarkably similar impact. They reduce the way in which the lungs fibrose by about 50%. And both of them do have side effects, unfortunately. So pirfenidone or Esbriet makes your skin very sensitive to sunlight, so we advise that you wear a hat out in the summer and you use factor 50 sun cream pretty much all year round if you expose yourself to the sun. The nintedanib or the Ovef has gastrointestinal side effects, so it can cause nausea, diarrhea and weight loss. However, we have a lot of experience now with managing the side effects of these drugs, so we can help you by reducing the dose or taking drug holidays or using other medication to help the side effects or modifying your diet appropriately. So in most patients, we'll say start with a low dose of the drug and see how you get on before you decide not to take it because you're worried about the side effects, as some people don't have a problem at all. The other drugs we use are in the patients who have inflammatory disease that's causing lung fibrosis, so those patients with an underlying autoimmune rheumatic disease. And the drugs that we use there will be the drugs that we use to treat their underlying disease. So for example, with rheumatoid arthritis, these medications will include prednisolone or steroids, and also drugs such as rituximab or anti-B cell therapies, which are becoming standard use in rheumatoid arthritis and also appear to reverse some of the lung scarring that we see in these diseases. In very, very selected cases, we can refer patients with severe end-stage pulmonary fibrosis for lung transplantation, but this is really only suitable for a handful of people who are at the younger end of the spectrum, so patients in their 50s and early 60s. And what I always say to these patients is a lung transplant is not like changing your batteries. You won't suddenly feel completely new. You're exchanging one chronic lung disease for another. So you will remain on medication all your life and on hospital follow-up all your life. But in most cases, the advantages of lung transplant are far greater than the disadvantages in those patients that we put forward for that very specific treatment. This is a question that all our patients want to know. What can they do to help manage their disease? And I would say there's a lot you can do as a patient. So all our patients should be encouraged to exercise. And some of you, that may seem a bit of a tall order, but even just a short walk around the block, or even if you can't do that, just a short walk around the room every day, several times a day, just to keep your muscles strong and remind your lungs how to deliver oxygen to muscles when they start working. For those of you that can manage it, longer walks are fantastic, and any other sport that you enjoy. Even just getting outside with a friend can be very helpful to lift your mood and help with the symptoms. We also suggest a healthy diet and for you to maintain a healthy weight. One of the issues we have is that some of the medications for pulmonary fibrosis either cause you to eat more and increase your weight, such as prednisolone, or you lose your appetite and you reduce your weight, such as OVEF. So maintaining a really healthy body weight is very important. There are other things you can do. Join with groups of friends to do things together. I think company is very important. And singing is something that a lot of our patients have found a lot of improvement from, because it actually helps them regulate their breathing and just breathe a little bit more efficiently. So there are plenty of things you can do that will help. Of course, the key thing I should have mentioned right at the beginning is stop smoking. But many of our patients have long given up smoking by the time they come to us. But if you are still smoking, that's a very big no. There is so much interest, which was started off really during the COVID pandemic, of home monitoring. So what this means is really keeping an eye on patients' symptoms whilst they're at home, so we don't have to keep bringing them into hospital. I would say that if you have stable pulmonary fibrosis, then you can probably be seen every 6 to 12 months by your specialist. However, if you have more progressive disease, and we like to see our patients every 3 months, and sooner if they have very progressive disease. Some of our patients can be managed at home, those who are happy and confident using a pulse oximeter at home and can tell us when their symptoms worsen or their oxygenation of the blood as measured by the pulse oximeter worsens. But at the moment, we don't have very good home monitoring for in other ways. We are trying to develop home spirometric measuring, by which patients blow into a spirometer every day and send their results to us. This is quite onerous for patients and also can be quite challenging. But actually at UCLH, we're really trying to understand a bit more whether we can monitor patients more safely so that we can get very early indicators of when their disease is progressing more quickly than it has done, and so when they need an input from the medical profession. So we're often asked this, and to be honest, as clinicians, we don't really stage pulmonary fibrosis. We recognise that there are patients with changes on the high-resolution CT scan but no symptoms. These patients, strictly speaking, don't have idiopathic pulmonary fibrosis or any sort of pulmonary fibrosis, but they have residual lung abnormalities, which we do need to keep an eye on to make sure they don't progress. But once you actually have a diagnosis of interstitial lung disease or pulmonary fibrosis, we recognise early disease or mild disease, and then moderate disease, and then more severe disease. And usually we define whether you are mild, moderate, or severe depending on your symptoms and your lung function and your imaging. But very, very crudely, if you have a forced vital capacity, which is one of the lung function tests, of above 80%, then we would say you have very mild disease. If you have a lung function forced vital capacity of 50 to 80%, then we would say you have moderate disease. And if your forced vital capacity, or FVC, is less than 50%, then we would say you have severe disease. And I think that's a reasonably good demarcation of the stages of pulmonary fibrosis. But unlike other diseases, you don't necessarily progress through the stages. You might have mild disease and stay mild, or you might very quickly progress to severe. Oh, this is such a rich question, because pulmonary fibrosis is a group of over 200 different diseases. And one of the problems we have is that the diseases are very heterogeneous, by which I mean they can appear very different in different individuals. And it really is an area where precision or personalized medicine comes into its own, because every patient behaves differently. Every patient with idiopathic pulmonary fibrosis behaves differently. So it is a very heterogeneous disease. Can it be cured? In some cases, when we know that the pulmonary fibrosis is caused by another underlying disease, such as rheumatoid arthritis or drug-induced, for example, if you've been taking amiodarone for your heart and you develop pulmonary fibrosis, then by treating the underlying disease, by treating the rheumatoid arthritis, or by stopping the toxic drug, by stopping the amiodarone, we may be able to reverse and maybe even cure the pulmonary fibrosis, and you may not have another problem from it. However, in the more severe cases, so for example in idiopathic pulmonary fibrosis and in other of the progressive pulmonary fibroses, we may not be able to reverse the disease, we may only slow it down. And in these cases, we cannot cure pulmonary fibrosis. It's one of the great sadnesses of this disease is that we do not have a cure for most cases of pulmonary fibrosis. Now, in a very, very select few of younger patients who are otherwise very well, we can offer lung transplantation, which is the closest we get to a cure. However, as I've mentioned on other videos, which you may have heard, lung transplantation, I always warn patients, it's not a quick fix. It's not like changing your batteries. You don't suddenly have a new set of lungs and you feel fantastic. What you're doing is you're switching one chronic lung disease for another. What we know is that most patients who have lung transplants do feel better, can do more, have a greatly improved quality of life, but they will still remain under hospital care for the rest of their lives, and they will still have to take drugs, many of which have toxic side effects. So I would say, honestly, no, we can't cure pulmonary fibrosis. As for life expectancy, as I've said, and as you can imagine, with such a heterogeneous group of diseases, it's very hard to know how each specific patient will progress or not. So we can see very different outcomes for two patients that appear very similar at the beginning. One might go for 10 years with no progression, and the other might die within 1 or 2 years. So it's very, very hard to predict. What we do know is that in most of the progressive pulmonary fibrosis patients, so these are the ones with the most severe pulmonary fibrosis, average life expectancy without treatment is 3 or 4 years, but there is an enormous spread. But on average, 3 or 4 years without treatment, and with treatment, that probably extends to 6 to 7 years. But again, I really have to emphasize that is when you look at the whole population on average, and there'll be some patients that get worse and die much more quickly than that, and there are others that seem to go on for a much, much longer time. In most cases, we get an idea of outcomes from how patients have previously behaved. So if you've been stable for 10 years, it's highly likely that you'll be stable for another 10. However, patients do continually surprise us. Equally, if you've been getting worse very quickly over the last year, the chances are you'll continue that trajectory, but not always. So we have to watch every patient closely and advise each patient as a unique individual. So again, another really good question, because pulmonary fibrosis does cause lung damage and makes the lungs stiffer. And one of the problems that ensues is that as the lungs have less oxygen, the blood vessels in the lungs actually constrict and become much smaller. And this means that as the heart pumps blood through the lungs, it's having to work much harder to get the same volume of blood through these much smaller blood vessels. So the right heart will eventually be under so much pressure that it will start to fail. And at that point, patients will notice a dramatic increase in their shortness of breath, and they may develop swelling of the ankles and particularly more shortness of breath when they are exercising. So this is called pulmonary hypertension. And the way we treat pulmonary hypertension is to use diuretics to get rid of some of the fluid, so the heart isn't having to work quite so hard. We also make sure that the patient is really properly oxygenated, particularly at night when they're asleep, because this again takes some of the pressure off the heart by opening up the blood vessels. That's really probably the biggest complication of pulmonary fibrosis. We also know that patients with idiopathic pulmonary fibrosis are at increased risk of lung cancer. So we're always very careful to screen these patients appropriately to make sure that if we do pick up an early lung cancer, we do it as early as possible so that the treatment is the least invasive that it has to be. The other problem with pulmonary fibrosis is it can cause weight loss, and it can cause a weakening of the muscles just because they're not used as much. So the medical term for this is sarcopenia. And what we know is that if you are a patient with pulmonary fibrosis and you develop muscle weakness because you can't exercise as well and you're not eating as well, then this does reduce your life expectancy quite dramatically. Well, this is a question very close to my heart because we do a lot of clinical trials, because it has to be said, although we have treatments at the moment for all the different types of pulmonary fibrosis, I would say that the treatments have limitations. They may not cure the disease, they just slow it down, and they often come with side effects that many patients find very, very difficult. So I would say throughout the country, most hospitals will be able to refer you to take part in a clinical trial if you want to with pulmonary fibrosis. And usually these trials allow patients to take part who are already on treatment, so you don't have to stop your regular treatment for pulmonary fibrosis to take part. It's an add-on treatment. Many patients enjoy taking part in clinical trials because you get seen more frequently. Often the hospital will arrange transport, which is funded by the company that's trying to develop the drug. So you'll be taken and ferried to and from the hospital for more frequent treatments. And even if you draw the dummy drug, which I'll explain in a moment, it's still showing that patients in clinical trials actually do better than patients that don't take part in clinical trials. So when you do take part in a clinical trial, you're often offered either the real drug or the dummy drug, which is a placebo, which looks exactly like the real drug, is taken in the same way, but neither you nor your physician know whether you have the real drug or the dummy drug. And the idea of that is so that we can really see if the drug makes a difference or whether it's just a so-called placebo effect. In most cases, your chances of getting the dummy drug are less than 50%. So, for example, for every 2 or 3 patients given the proper drug, 1 will be given the dummy drug. But as I say, even if you're given the dummy drug and you take part in a clinical trial, you do seem to do better, probably because you're watched over so closely by the medical team. So this is a very important question because the National Health Service can do so much, can treat you with medications or oxygen, but actually we've already discussed the time between appointments may be quite drawn out, so you may not see your physician for 3 months. And what can you do in the meantime to draw some help from either online or community resources? So I would say they're very good online resources. Action for Pulmonary Fibrosis is a UK-based charity that supports patients with pulmonary fibrosis, and Breathing Matters, of course, has patient resources. There are also patient groups. We have one at our hospital that meets every 2 to 4 weeks, and they discuss different aspects of pulmonary fibrosis. And there are also online communities. And I think Action for Pulmonary Fibrosis is a great supporter of patient groups, both online and in person. They certainly support our patient group here at UCLH. There are also other resources. In person, we can sometimes arrange community physiotherapists, but I think really importantly is your community gym, which may have classes for patients with lung disease. Once you've checked with your physician that it's all right for you to take part, then I can really recommend joining a class or a group for older people or even older patients. Many of our patients get introduced to exercise through pulmonary rehabilitation, which is organised in the community. And then from these classes, they're then advised how to go about continuing the exercise regimes, either at the gym or at home. We're hoping to produce some online videos to help with breathing. I can link some of them below. So this is just to help you use your diaphragm more when you breathe, which is really important. And also some links to other groups and exercise classes that can be done in the comfort of your own home.